Pathopharm Module 3 drugs. So first we have cilostazol. Cilostazol is a vasodilator and an antiplatelet. It's direct acting and peripheral. Therapeutic use treat PVD and intermittent claudication. So the mechanism of action of cilostazol is it inhibits platelet aggregation and also vasodilates. The side effects include peripheral edema, CNS effects, the cough, rhinitis, and nasopharyngitis. Adverse reactions are cardiac effects, so tachycardia, palpitations, heart failure, etc. Nursing considerations for this, you take with a full glass of water. Do not take with food or grapefruit juice. And it takes up to 3 months for a therapeutic effect. If you smoke, you're going to get a vasospasm, and if you drink alcohol, you're going to get hypotension. Life-threatening effects, multiple cytopenias, and then drug-food interactions. Aspirin and warfarin, you'll get an increased effect. Grapefruit juice, you'll get an increased effect. And St. John's wort, you'll get a decreased effect. Next, we have atorvastatin. The drug class is an anti-hyperlipidemic. The therapeutic use is that it decreases cholesterol levels and serum lipids. The mechanism of action is that it inhibits HMG-CoA, and it decreases LDL and triglycerides, and then that decreases the total cholesterol. The side effects are CNS effects and MSK pain. The adverse reactions are rhabdomyolysis, which in an emergency, it's a tea-stained urine and lower back pain. And then another big one is tendon rupture and then hyperglycemia and myalgia. Contraindications are hepatic disease and caution in pregnant women and alcohol use disorder. Life-threatening is hepatic and renal failure, stroke, and cytopenias. Some nursing considerations, we want our desired value for cholesterol to be less than 200. An annual eye exam and report vision changes. Report unexplained muscle tenderness or weakness, and do not stop abruptly, which could lead to an acute MI. I believe with atorvastatin, that's the one that you monitor for cataracts. Next, we have our 4 antihypertensives. First up, we have metoprolol. The therapeutic use of this is to control hypertension. The mechanism of action is that it blocks beta-1 receptors and cardiac myocytes. The side effects of this include CNS effects and peripheral edema. The adverse reactions are orthostatic hypotension, thrombocytopenia, and diabetes mellitus. Life-threatening interactions with this include dysrhythmias, bronchospasms, and heart failure. Contraindications are hypersensitivity and cardiac conditions. We want to use caution with people with asthma and COPD. Nursing considerations, abrupt discontinuation can lead to rebound hypertension. Also, hypoglycemia, and we advise against over-the-counter drugs without first consulting the provider. We also have cardio effects of the B blockade. So we have negative entropy decreases contractility. So a little thing was, I know a lot about contractility, or I know nothing about contractility because inotropy decreases contractility. Negative inotropy. Then we have negative chronotropy, which decreases the heart rate. Next, we have prazosin hydrochloride. That is an antihypertensive and an alpha adrenergic blocker. It controls hypertension, and it blocks alpha-1 receptors in the sympathetic nervous system and smooth muscle, and dilates arteries and veins. This leads to a rapid decrease in blood pressure. We call this the first dose phenomenon. Side effects for this include the CNS effects, which is dizziness and drowsiness, and adverse reactions are cardiovascular effects, which is orthostatic hypotension, palpitations, and tachycardia. Contraindicated in pregnancy and breastfeeding, and caution in orthostatic hypertension and fainting. Nursing considerations report low urine output, report sudden decrease in blood pressure with tachycardia. Advise that abrupt discontinuation may cause rebound hypertension, and advise against over-the-counter cold cough drugs. We also want to monitor the patient for 2 to 6 hours after giving this. Next, we have valsartan. That's another antihypertensive, but it's an angiotensin II receptor blocker, ARB. The therapeutic use is that it treats hypertension, and the mechanism of action is that it inhibits angiotensin II from binding to angiotensin I receptors. That makes vasodilation, and that decreases PVR. Some adverse reactions of valsartan is orthostatic hypotension, hyperkalemia, and rhabdomyolysis. And then we have our elevated hepatic enzymes, which are our LVTs. Life-threatening is angioedema, neutropenia, and renal dysfunction. Contraindicated in pregnancy and breastfeeding, and renal disease, which is a really big one. Drug interactions include alcohol, which exacerbate hypotension, and aspirin, which exacerbate hyperkalemia and renal dysfunction. This medication is less effective in African Americans. Our next antihypertensive drug is amlodipine. Amlodipine is antihypertensive calcium channel blocker. It treats hypertension, and it blocks calcium channels, inhibiting influx of extracellular calcium across myocardial and vascular smooth muscle cell membranes. It decreases myocardial contractility and decreases peripheral resistance, therefore decreasing the blood pressure. For the side effects for this one, it is expected to have drowsiness, flushing, and headache. Some adverse reactions are cardiac effects, so our bradycardia and our tachycardia, chest pain, and palpitations. Another adverse effect would be dyspnea and hyperglycemia. It is contraindicated in hypersensitivity, hepatic disease, coronary artery disease, and myocardial infarction. Caution in older adults, pregnancy, and breastfeeding. Life-threatening would be angioedema, dysrhythmia, and thrombocytopenia. Nursing considerations, it is actually better to use in African Americans. And drug interactions include NSAIDs, which lead to renal dysfunction, codeine, which lead to sedation, cold medicines, reduced effect. Next, we have hydrochlorothiazide. That is a thiazide diuretic. The side effects include dizziness and blurred vision. Therapeutic use is to increase urine output and treat hypertension. The mechanism of action is that it acts on renal distal tubules. It promotes sodium, potassium, and water excretion. It decreases preload and cardiac output and edema. It acts on arterioles, which therefore make vasodilation, and then that decreases blood pressure. Adverse reactions are all the hyper and hypos, so hypercalcemia, hyperuricemia, hypercholesteremia, hyponatremia, hypomagnesia, etc. Contraindications are hypersensitivity, caution in hepatic and renal dysfunction, hypotension, electrolyte imbalance. Life-threatening is hypokalemia, Stevens-Johnson syndrome, renal failure. Nursing considerations include to have the patient get up slowly from lying down due to possible orthostatic hypotension, monitor fluid and electrolytes, inhibit calcium excretion. Next we have furosemide. It is a loop diuretic, and the adverse reaction is orthostatic hypotension, hearing loss, and electrolyte imbalance. Therapeutic use is to treat edema due to heart failure, renal dysfunction, hepatic cirrhosis, and nephrotic syndrome. It's also used to treat hypertension. Mechanism of action, it inhibits sodium and water reabsorption from ascending loop of Henle in distal renal tubules, and that increases excretion of electrolytes. Side effects are tinnitus, dizziness, headache, weakness, blurred vision, and photosensitivity. Life-threatening is Stevens-Johnson syndrome, anaplastic hemolytic anemia, thrombocytopenia. Contraindicated in hypersensitivity, hepatic disease, acidonuria, and caution in electrolyte imbalance. Clinical judgment, observed for hypokalemia, IV onset in 5 minutes, weigh daily, and monitor urinary output. You need at least 600 ml a day. Lastly, we have spironolactone. That is a potassium-sparing diuretic. The therapeutic uses is to treat edema, hypertension, and heart failure, hypokalemia. Mechanism of action, it inhibits aldosterone effects on distal renal tubules, sodium and water excretion, and potassium retention. Side effects are erectile dysfunction, adverse reaction, orthostatic hypotension, and electrolyte imbalance. Contraindicated in hyperkalemia, life-threatening hyperkalemia if given with an ACE inhibitor. Caution in renal hepatic dysfunction. Clinical judgment include observed for hyperkalemia, which is over 5, weigh daily, and monitor urinary output.